Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and today we're going to talk about when do we need to intervene with second molars, especially, or we call these sevens in some other countries. In the US, you're talking about teeth number 2, 15, 18, and 31. When do we need to intervene? When is it a problem? And this comes up fairly commonly when I work with my clients, especially my general and pediatric dentist clients. They're taking perhaps a phase 2 or a comprehensive ortho case, maybe for Invisalign. And I'm like, whoa, pump the brakes. We're screening this patient and we're looking, and I said, are you looking at the pano? And I'm not specifically talking about this pano, but I always say, are you prepared? This tooth might get stuck. Are you prepared to do an explosion bond? Are you prepared to intervene? Are you prepared to go back and do sectional braces, do lower braces? Do you know how to do, say, a Halterman appliance? And they're like, no. So ligation and issues with second molars is not the greatest for aligners. I mean, that's one of those rare things where I tell you guys, you can do anything with Invisalign pretty much except that. So that's one of the only things. And I have done a case and I've done some funny things with cantilevers. There's no way you guys are going to be able to learn how to do that. That's something you absolutely have to do in ortho residency. And it's even the stuff I don't even like to do, but I know how to do it because I went to University of Connecticut, which is totally all about biomechanics, cantilevers, intrusion arches, and we learned how to bend funky stuff, and how to do moments. And it's not even like a step bend in a wire. I mean, it's complicated, and it's such a one-off at this point that I don't see any reason that a general or a pediatric dentist would need to train for that because it's such a one-off, especially if you do early intervention and you're screening for phase 1 and you're doing what you need to do to prevent these things from happening in an older patient. So, and here's the beauty is you guys can always refer these patients out. Please do refer them out to ortho, It's beyond the scope of what you can do. So don't take these cases unless you're prepared to take them all the way to the end. If you're accepting this D80, 80, D80, 90 case, comprehensive or phase 2 ortho, you're accepting all the issues that come, including the impacted second molar. So you need to screen them appropriately. And, a good orthodontist with a lot of experience is going to be able to look at a panel on a 10-year-old and be like, this might become a problem in 2 years, or an 11-year-old. It's not a problem yet. We're going to put it on a watch. We're going to do a few things, but we're prepared to go in and switch to braces when it happens. So when do I think something's a problem? Well, first thing I always recommend is just like you learn in dental school, whenever you're screening radiographs, is you're looking at symmetry, right? So if, let's say, for example, and I'm sorry, I don't have the best x-ray here. I mean, I had to get one that had a release on it, and I didn't have one that was like really funky. I see them all the time. But, if you see number 2 or the upper right 7 fully erupted and the left one is doing some funny things, well, that's a problem. Anytime there's symmetry, issues with symmetry, same thing on the bottom. Impactions most commonly happen on the lower. And one of the easiest ways to intervene is to remove the 8s or the third molars, even if the patient is 12. There's always an oral surgeon who will do it. And I know it's not normal to take third molars out if the patient is very young. But if you have a reason behind it, they will. They definitely will. You don't have to take out all 4. That's a major surgery. You could just take out 1, and there's no reason they need to be sedated for that. It's a minor surgery. And when it's a little ball right here, these would be big surgery, right? Because they're way up, but I'm talking about lowers. When it's a little ball, it's pretty easy for them to do a mild incision and just pluck that sucker out. So that's the easiest thing you can do. I also have a lot of other simple interventional techniques. If you want to watch my other videos on second molar tricks and tips, you can go into my YouTube channel, which is Straightsmile Solutions, put in the keyword second molar or sevens, and it should come up, impacted second molar. And I have like a spacer technique where we talk about the Halterman appliance. There's a lot of stuff that you can do to intervene, but that's the main thing. Just look for symmetry. Obviously, you're looking for teeth that are angulated mesally. That's a concern whenever they're angulated mesally. Once they get up over the height of contour, we're usually free and clear. So there's definitely some things you can do. Obviously, if you're doing phase 1, if you're expanding the arches to the right size when they're supposed to be expanded, not waiting until they're older, but when they're little, that gives more space so that things don't get so bunched up, and they're more likely to get around that height of contour and to upright themselves. So do keep your eye on those. Intervene as needed, take out 8s, and keep in mind if it's crazy impacted, occasionally you'll find one that's just like horizontally angulated, like 90-degree angle. that's probably going to be very difficult to upright and it may not happen successfully. So sometimes in those cases, before that tooth is fully developed, we're going to go ahead and shuck out that second molar. We're going to leave the third molar, and we're just going to hope and pray that it develops correctly and just kind of drifts into place. Keep in mind that that's a little bit of a confusing situation. So if you do decide to do that, first of all, I really don't want you guys as general and pediatric dentists to be pulling the plug on that. I don't want you guys making that decision. I'd rather an orthodontist and an oral surgeon make that decision together. I just don't think you guys have the experience to make that decision. But you know, if you decide to make that decision and pull the second molar out at an early stage, be it, age 9, 10, 11, you see one that's just going to be real bad, and hope and pray that that third molar is going to develop, vertically and or drift into place. It may or may not happen. Usually it's going to need a little bit of assistance from ortho. Keep in mind, by the time that third molar erupts, the patient's going to be probably 16, 17, 18, 19. So this may not be something that you're doing in your regular comprehensive phase 2 braces, right? It may not be. So it might be something they're going to have another unit of braces later in life, which is an additional expense for the family, and that's something you need to let them know. So if you're not going to be treating them to the point of uprighting that third molar as needed or assisting it to come into place, if it's even possible, then you need to make sure the family knows that, so that they can plan accordingly and they can decide, do they even want to do this phase of braces now, or do they want to wait until the child is older so that they can handle all the problems at once? But again, you can never make any guarantees with these things. So just keep that in mind. All right, hopefully that was helpful. I know this was a lot of vague information, but I just feel like so many times docs are taking cases, with 10, 11, 12, 13-year-olds without realizing that they're responsible for all the teeth that are coming in from 7 to 7. So don't take the case unless you're prepared to handle all the issues that may come up. So it's always better to run your cases by an orthodontist first. All right, thanks so much.